Yeah, so as I've sort of dabbled in the realm of healthcare, um, I've sort of come to realize that I'm really passionate about critical care, especially. Being an EMT and an ER tech, I've sort of noticed a lot of these vascular procedures and their importance, especially in the realm of critical care. Um, right now, for nursing school, I'm doing my clinicals in the ICU at Yale. But he has, a plethora of types of, vascular access. And these things are having life-saving medications and fluid going through them at all times. I've been talking to a bunch of people as I've become more interested in it to sort of learn a little bit more about it. And the best procedures, the most frustrating procedures, and a lot of the nuances around some of these devices and techniques and things like that. And I've come across your content over the years, and a lot of people that I talk to and work with have as well. And I sort of figured out, I'm going to reach out. I feel like there would be sort of no one better to talk to sort of give me some input on it.
Oh, there's so many better people to talk to. You just don't know them.
Yeah. So, I mean, I guess like, first of all, I'm sort of wondering like about your current role in healthcare and like sort of your specialty and what you do.
Yeah, it's a good question. So, the title I like to give myself that I heard someone say once, and I was like, oh, that's pretty cool, is interventional vascular access. What does that mean? Basically, we do a
Okay.
lot of the vascular access work under your skin without cutting you down. So, just like interventional radiology, this minimal invasive, invasive procedures with minimal invasiveness. So instead of cutting you up like surgery does, interventional radiology does it with the minimal amount of damage. And so with vascular access, it's that. So I use ultrasound. Every once in a while, we'll use X-ray. But for the most part, we're using our tools and our skills and techniques and what we know to get that access the best way possible. You might have heard of other variations like PIC team, IV team, IV therapy, things like that. The reason why I like to distinguish the title differently is because I do a little bit more than just PIC. I do a little bit more than just IV. We do pretty much everything required for fusion therapy except for ports and Swan Gans. Um, and RICS. I don't place RICS either because I'm not usually there when the patient needs MRT, when they are in the trauma itself. I'm usually called after they've stabilized the patient, unless I happen to be there while the patient is stabbed or like like they're bleeding profusely. But even then, at that point, there's a whole team at that code. I don't need to be there. Usually, after they're stabilized is when we're called, and so I stick to that. So, started out in ER, worked as an ER nurse for a few years, and then went into vascular access after a buddy of mine. I didn't even know it was a thing until I knew there's like an IV team, but I was like, we're the IV team, who cares? And then
Yeah.
I heard that they're doing a lot more invasive procedures, and a buddy of mine told me about the job. And to be honest, I didn't even know what a PIC team was or I knew of a PIC catheter because patients very rarely came in with it, but we never used it because we didn't need to. Um,
Yeah.
and so, yeah, I kind of fell into it. A buddy of mine invited me into the job that he was working with, and fell in love with the specialty, and continued on and kind of doubled down on it.
Wow. That's it's really interesting. Yeah, I find a lot of those access procedures to be really interesting. I mean, even during my clinicals, if we see someone in your position performing one of those procedures, it's like immediate our professor throws us in the room to watch and learn and kind of understand the importance of these kinds of things, especially because the nurses on the floors in any kind of setting where people have these advanced access devices, we're going to be the ones taking care of it a lot of the time too. So there's a lot of important things to understand when it comes to maintaining them and things like that to prevent things like infection and whatnot. Um, and I sort of wanted to get your um, input, I guess, on that too. Uh, I mean, I guess I'll phrase it like this: like if there's any sort of advice you would give to a new grad starting out and they're taking care of a patient with these kinds of lines, besides what we're taught in school, what are some things that you think would be important to know to take care of patients with these kinds of lines?
Oh, it's a really good question. I don't know what it is about school that does not cover this extensively. I think it has to do with lack of leadership in general, but there's some resistance to teaching this at a higher level for nursing schools. In general, I think our overall education in the license has gone down over time. They've dumbed it down for people to pass more easily, which is a very dangerous thing. However, political pressure of like, hey, we have a nursing shortage. Nursing organizations, what are you doing?
Yeah.
It's like, well, our standards are a little too high. That's a theory. Another theory is because schools are funded by your success rate, your pass rate for the NCLEX, for the boards, it's partially subsidized. There's some funding that comes from that. Uh, there's not a lot of NCLEX questions about vascular access because the leaderships in that credentialing space thought it unnecessary to teach
Yeah.
or to test. And debatably, yes, not everyone will put in IVs, but majority of us are working at hospitals. That's where the nursing shortage is, and at nursing homes. Um, so these facilities that patients are at, nurses are doing these procedures and they deem it still unnecessary, because they think it's not enough people doing it, which I think is a wrong assessment and assumption. But I'm not in that leadership position, so I don't know why they're not. But so as a student, what can you do? There's a couple things. Create a club. Canada, I think Quebec or Toronto. I'll find out for sure. There's a school out in Canada that has their own vascular access club, and it was supported by a faculty member, a professor who is not in the specialty space, who saw the value of it like you did and said, this is important stuff. Like, why is there not more attention around this education? And so I think schools are starting to wake up and find that this is becoming, not schools, but people in general, clinicians and educators and students are finding out this is becoming a very important thing. The reason why I'm going over history is because I think we need to understand where this lack of initiative comes from. And understand vascular access is a new space, relatively speaking. Debatably, it started with Suzanne Herbst in the 1980s, where she created an organization to gather physicians and nurses and other clinicians together, pharmacy together, to discuss this thing called catheter abuse. So we are doing these procedures invasively and at scale, and we're not investigating how to do it better. And so she started the specialty group meeting, and I think the specialty itself kind of stemmed out from that. And it's a multidisciplinary specialty. It's not just nurses putting in lines, it's physicians, it's RTs, it's techs, it's MAs. Like there's a lot of other licenses that are doing these things. So before that, it was recently in the 60s, uh, debatably 1950s, where IV plastic bags were a thing. And so we were able to scale up production of IV medications to be able to give patients IV therapy in general. So it started out with a handful of meds like IV fluids, different types, and then it expanded since the 60s. So in about 70 years, it expanded to over thousands and thousands of medications, and delivery systems through the IV. And so now it's grown so quickly, the need for IV access, but our didactic research and innovation have not really caught up with it. And
Yeah.
so it's really cool to see that before it used to be elder nurses. And when I say elder, I don't mean like, in their 80s. It's nurses have been doing it for a lot longer, uh,
Yeah.
10 years plus, 5 years plus, probably 10, 20 years plus, who join the organizations, particular organization, Association for Vascular Access, WACOVA, INS, and things like that, to discover and investigate at a higher level. And it wasn't until I think recently, like you guys, starting to find out earlier, like before you're even graduating school, you're finding out, oh, that's a thing we can do. And so I'm hoping that, through social media and stuff that you're finding things out, which obviously you guys are, and starting to come into our space younger because
Yeah.
we need fresh eyes. We need literally fresh eyes to do the procedures, fresh hands and brains to investigate things for the next 30 years that you guys are going to be in your careers. And
Yeah.
so I'm very excited that you're interested. I'm very excited that I'm hearing students are interested. And so I think it's growing and you're at that beginning stages and growing pains of this specialty. And you're kind of in the middle of it. So that's
Yeah.
why I think there isn't any, but the resourcing. So you guys have to kind of find your resources right now. Let me give you some
Yeah.
off the top of my head you can rely on.
Sure thing.
Join the Association for Vascular Access. They have huge discounts for students. I think it's free. Uh, if you incorporate I forgot what they called it. AVA has a PIV and IV uh, course they can integrate with your program. So if you're like, hey, you go to your professors and say, hey, look, Ava is going to do it for free. They're going to pay for it. Like you don't have to you don't have to pay for anything. You just have to agree with the curriculum that Ava has standardized. And I can give you the email for Tony and Judy. They'll gladly
Sure. Absolutely.
sponsored by Bebron, so it's paid for by a company, multi-million-dollar company who is about educating clinicians. Like huge, big deal. That's why
Yeah.
I like the people that work there because that's what the leadership is focusing on. Not just selling our equipment, but educating properly enough to spend
Absolutely.
money on free programs for schools. So
Yeah.
if you guys are in that program, and Ava comes in and works with you guys and incorporated, all the students and the professors will have free access to Ava. That's a few $1,000s or a few $100s. And the conference itself is about 1,000. So it's a pretty
Wow.
pricey membership that you guys get for free. So that's
That's
the
amazing.
access. So the Association for Vascular Access, intracav.ai, I've got to promote it because it's the only thing out
You
there
got to.
that's as robust that I know of. Um, so intracav.ai is vascular access contextualized, and it's basically RAGed for all our software engineers. It's RAGed on data and documents that we trust. So, Shea, Kadoki, Chest, INS, ONS, AACRN, all these organizations, ENA, all these organizations that are our thought leaders for our specialty spaces, it's IntraCav is taught on those documents. Not all of them that I named, but we're slowly feeding it because it takes a lot of time and money to actually teach it how to contextualize the information. So for medical or healthcare related education, IntraCav is probably the closest thing you'll get to accuracy.
Oh,
Another thing is to connect like you are, connect with specialists online, connect with specialists that are on like papers that you read, studies that you read. Like, some of them are out of reach because they're so busy, but others might be just starting out and have the time for you like I am. So taking the risk and reaching out and say, hey, how do I get to where you got is going to be key. Um, I'm trying to think. Yeah, the study, yeah, like Ava. Ava's it. That's the most important one. Secondly,
yeah.
IntraCav, that way you can look things up more faster while you're studying. And look, when you guys are studying, and even when you're a new grad, there's so much you need to learn. You need to learn how to talk to doctors you've never done before as a student, kind of.
Yeah.
You need to talk to other nurses, the charge nurse, which you've never done as a student, pretty much. Um, You need to learn how to navigate orders, medications, how to talk to patients at independent level at this point. There's so much that you guys are learning that you guys are still trying to figure out. There's not a lot of bandwidth to sit down and study at this higher level.
Yeah.
Let Intracav make that much smoother, easier. Literally, it's an AI chatbot based on vascular access. So if you have a question while you're on the floor, while you're in school, or while you're in your clinicals, it's gonna give you the answer a lot faster than a lot even a lot of the people there will be able to answer for you.
Yeah, that's great. And I think it's amazing that they do that for nursing schools, especially because, I still remember when I started, one of the main questions I had for all of my professors was, when are we going to learn about IVs? When are we going to learn how to insert them? When are we going to learn how to push meds through them? And I feel like it's such an underserved thing. We don't learn how to insert them. And we learn how to do meds through them, of course, because it's an important part of our practice, but probably not to the extent that we should. And we don't learn about all these different nuances about them. Um, and so I'm really actually happy that you told me that. And that's something that I definitely am going to bring up. Um,
Here's another cultural thing involved with that. First of all, how many people, you're not going to know this, it's a rhetorical question for the
yeah.
listeners. First of all, how many people, how many clinicians, let's say nurses, are good at IVs in the first place? Not a lot. I'd say less than, I'm just making this up in my head, less than 40, 30% are really good at it. Uh, and then how many of them are teaching? And so the
Way less.
professors that are there, probably the statistically they're not really good at it. And it's a skill. There's very little didactics on how to make you better. And so who are they to teach? It might be what they're feeling, it might be what they're thinking. Like, I'm not good at it. Why would I teach something I'm not good at? And so that could be part of why there's a lack of education there as well. Um, so yeah, having Ava to come in and do it for them, that's a big deal. And I don't know if they don't know about it. I've heard some schools reject it. Be like, nah, we're good.
Oh, interesting.
We don't care for it. Either it's too much of a
It's,
headache to integrate, which I don't think it is. It's literally just letting them come in and do their thing, or they're like, "Oh no, we want to take it and make it ourselves," and you can't. You're not a specialist. Like, why would you? Like, you can't.
yeah,
Everything you edit for is gonna be worse. Like, let
I think
Ava
that's
come
really
in.
interesting. Like some of the rejections, especially because how hard hospitals push to prevent infections related to vascular access. So that's really interesting to me.
And here's something exciting for students. Well, might not be exciting because you're not doing sexy stuff like chest compressions and and IV meds and stuff like that. So,
Yeah.
uh, right now, it's a big punishment for hospitals to get caught with the central line, PICC line, central line bloodstream infection. They're changing it now to all infections. We don't care where you get it from. We don't care if it's from a central line, from you spitting in the patient's eye, whatever it is, from a PIV, whatever it is. If the patient gets an infection on your watch and they didn't have it before, you guys will lose thousands of dollars.
Yeah.
Sometimes, very rarely, but sometimes hundreds of thousands. Um, and so now the PIVs are going to get dinged. And so for students out there, those who know how to take care of it and do it well are going to be the ones who are ahead of those who didn't care for years. So this is your time to start paying attention because it's going to start mattering, if not
Yeah,
already. Yep.
definitely. I wanted to ask you also about some of the vascular access devices.
Okay.
I feel like I feel like that's a rabbit hole that in itself that you could go down for hours. Um, but I feel like a lot of these there's a lot of different there's a huge variety of different devices and what they do and where they go. And I feel like that also is not taught. And I've come across a lot of nurses who don't really know about certain devices and what they do. And so I kind of wanted to just ask you about some of those and like which ones you sort of find valuable or frustrating and which ones you think we should know about that are actually really beneficial.
It depends on the floors that you're working. Sometimes you're not going to come across a Swan-Ganz for the rest of your life if you don't go to ICU.
Yeah.
ER, I've never seen a Swan-Ganz in the ER. I've seen a few central lines here and there, but rarely because they would place usually an IJ catheter, but Swan-Ganz is a very, very, very specific um, use case for treatment and therapy, and it's usually placed in the ICU where it's safer and cleaner. So let's start with categorizing. There's two big umbrellas of vascular access devices. There's peripheral IV, there's central venous catheter, so PIV, CVC, and then intraosseous, which is like its own little thing, which is the IO guns. So it's an IO needle that goes through your bone, and you can give medications through that access. So peripheral IV is mostly what you guys will see off the bat. And then central lines is when you start to specialize, is when you start doing it. Central line access is more invasive and takes more care maintenance because it's in there for so much longer. And usually we place those for very critical patients who need lots of medications that are not compatible and that will damage the smaller veins. Medications themselves are not homeostatic, meaning they will disrupt the glycocalyx protein inside of your veins one way or another. Even fluids is not homeostatic. So these chemicals are disrupting the natural state of things inside of our veins, some way worse than others, some tolerable, and we need the central line access to deliver it in a safe manner. What does that mean? The catheter tip is terminating and ending at about where the heart is. It's called the cavo-atrial junction. So that means the junction between the vena cava and the superior vena cava and the atrium. So cavo-atrial junction is where we want it to place. That way, the most amount of blood flow is diluting that medication so that the molecules of the medication are doing their thing, but the concentration of it is not damaging our body so quickly. So that's pretty much CVC in a nutshell. Peripheral IV is just an IV that ends like within the like around here before the brachiocephalic and terminates here on out. So everything distal to that point is a peripheral IV.
Okay. That's really good to know. Um, Out of like I'd say because of the fact that I think that, and you can correct me if I'm wrong, but because most nurses probably are dealing more with peripheral IVs, rather than anything central, what kind of devices or yeah, what kind of devices and sort of products would you say you think may be problematic um, for specific reasons, or perhaps something that's extremely valuable that you think there should be more of? Um,
So
if that makes sense.
this is great. So let's talk about peripheral IVs because you guys will be dealing with that. Almost everything else, it's at a higher level. You're not going to have to deal with it. You'll deal with it, but you're not going to have any choice and any authority to change anything about it until you get into the specialty. So let's talk about peripherals. Most PIVs are too short. They're about 2.1 centimeters. They need to be at least 4 centimeters. Yeah. So they're too short and they come out of the vein while inside of the skin. Uh, because the skin is so pliable is not the right word. It's so loose for a lot of our patients. Uh, and there's so much movement under the skin that we don't see. And so with that movement, there's going to be separation between the skin and the vein. And so that thing that's anchored to my skin, okay, it might be in the vein right now, but when they move a lot, it's going to come out of that vein and just sit in that tissue. and we're not going to know it, and we're going to say, oh, it's blown, we don't know why. And so having a long enough catheter is probably the number one thing that nursing students going into a new grad can complain about and try to get changed.
Great. Great. I mean, you told me everything that I sort of wanted to ask and more.
That's perfect.
I sort
So,
of
uh-huh.
I think sort of just like to sort of end it off, I guess, if there's anything that you would sort of want to leave with nursing students or new grads or anything like that about anything in general related to vascular access, what do you think
100%.
it
The
would be?
easiest, yeah, easiest thing. Not the easiest thing, but the easiest to understand. Get ultrasound trained as soon as possible. If they say no, we don't do that, uh, I don't know what to say. Like, do you really want to work there where they're not equipping your nurses?
Yeah, yeah,
And
it's a
so
big
this is
problem.
particularly right now culturally acceptable for ICU and ER to hassle their leadership for ultrasound training. The fact that they need to is quite stupid. But hopefully those older leaders who don't see value in that will start to phase out and retire the hell out so that younger leadership can come in and actually fix things. Um, in regards to vascular access. But if you're not, if you're at a med surg unit, I don't know how you can advocate for that. I mean, I do know, but it's going to be individual based on your institution. But if you're an ER ICU or if they do offer anywhere else, figure out how to get ultrasound trained as soon as possible because that is going to be your best bet. And I say bet because you can still be terrible with the ultrasound even though you're trained. It depends on how much you pursue the skill itself. It's like having a hammer. I can give you a hammer, you could be really good at it, or you could just break shit all day. Like, so it depends on who's wielding the tool that's going to be good. However, that hammer will help you build a house better than a rock will. Okay. So
Yeah,
so
that's a
try
great
to
way
get
to
off
put
the
it.
rock, pick up a hammer, metaphorically speaking, get the ultrasound as soon as possible, get trained as soon as possible. That will be at scale. You're going to help reduce suffering for the patient with what we do.
Yeah. I
And
mean, like you were saying with the ultrasound and having to sort of push back on management and things like that about getting nurses trained in it, I see that as an ER tech in the emergency room that I work with. And I hear nurses and see them talking about it, how it should be a standard thing that once you start, you get trained in it. I
yeah,
think it's not even a debate at this point whether or not it improves patient outcomes.
new grads put pressure during the interview. Ask them, "Hey, do you guys train on ultrasound?" They'll look at you like you stupid student. We don't do ultrasound. The hell are you talking about? Keep asking because it's going to be up to the younger generation to make it look cool to do ultrasound so that the old heads are like, trying to keep up with you guys, right?
Yeah.
So it's up to you guys to push for it. And so at every interview asked, do you guys train for ultrasound IV insertions? And the more students at scale ask for this tool during the interview, the more the old heads and the old guard will start to pay attention. This seems to be something that the students are really interested in. Like they might disrespect it, but they're going to start paying attention.
Yeah.
And I know some students, uh, they like medical students, they will part of deciding which school to go to depends on what they equip them with. And if they're like, hey, if you don't give me a butterfly or give me a portable ultrasound, like if you don't provide that for me and with my tuition that I'm paying you guys, and you can't even offer that couple thousand, few $1,000 device, I'm going to go to this school that does. And so putting pressure on programs, new grad programs like that will be a big deal. And they're going to listen. If there's 20 nursing students during the interview for their job asks for ultrasound training, that's a pretty noticeable culture shift that they're going to start paying attention to. So students, you have a lot more power in your hands than you think. Put pressure on them because if you guys don't decide to work there because they're not equipping you guys with what you need, they're going to figure it out quickly that they're losing recruits. They're not as sexy to work for.
Absolutely.
Yeah. So, yeah, man, are you planning? I gotta hop out soon too. Are you planning on going to critical care or ER?
Yeah, I see you.
Okay.
I'm like
So once you're
I've
in,
seen both, and I'm like 100% sure I want to go
good, good,
ICU.
good. Yeah, there's a bit of chaos and ADD that's required for the ER.
Yep.
My recommendation is because we need more critical care people in coming into the vascular access space. Um, get ultrasound trained quickly, and your first objective with that, and you're going to have so many other things to deal with, but the first thing you're going to want to get is when you feel like you're trying to gun for the vascular access specialty, which after about 1 or 2 years, you could be ready. It depends on how much you're studying during those 2 years. But during those 2 years, your objective should be 100 consecutive first stick successes in a row. So the next 100 patients you poke, all of them consecutively will get only one poke from you. And if you can make it
Great.
there, if you can achieve that goal, then you're ready for a vascular access specialty.
Great.
So hit me up next once you get to that point. When you're ready to start, hit me up because there's a little bit more than that I need you to
Yeah.
do so that you can get your brain right and ready for the specialty space.
Amazing. Thank you so much. I
Yeah,
can't
dude.
thank you enough for
No, of
allowing me to do
course.
this.
Well, I'm happy to help. You can reach out anytime. I'm happy to steer you wherever direction you want to go.
Alrighty.
Dude, it was a pleasure,
Thank you
man.
so
Nice meeting
much.
you.
Nice meeting you too. We'll keep in touch.
Take care.